For those of you who don't know him, this is Dr. Gong. He's one of our pediatric urologists here, and he's a specialist in minimally invasive surgery. I'm actually very delighted to hear this talk and the role of partial nephrectomy in Wilms tumor. So I think if the residents have joined in, which I think they have, you can take it away anytime, Dr. Gong, and thanks for doing this.
Oh, no problem. Thank you very much. First, thank you for inviting me to do this. As many of the residents know, in general, for pediatric urology or for pediatrics, Wilms tumor is managed by the pediatric surgeons. And it's just kind of a dichotomy that's developed over the years. At Lurie, one of the ways that I end up becoming involved is when a partial nephrectomy is necessary. And, so because of that, obviously I wanted to learn as much about partial nephrectomy as I can. And it was kind of a fascinating area of management, because obviously on the adult side for kidney tumors, if you can do a partial on it, you should try to do a partial on it. And the big discussion on the adult side is, well, why are people doing lap nephrectomies when they should probably be doing a partial instead? Right. So I started looking into kind of the use of partial nephrectomy for Wilms tumor. We'll go over, some background on Wilms and standard Wilms management. But then the meat of this is really going to be talking about kind of partial nephrectomy and perhaps a push for increased utilization. So Wilms tumor is also known as nephroblastoma. So the terms tend to get interchanged in the literature. Super common renal tumor of childhood. And it's an embryonal tumor, meaning that from the time the embryo is developing, there are immature remnants that will remain in the kidney that eventually turn into this nephroblastoma or Wilms. And the neat thing about Wilms is that from like decades ago, the management has been super well organized, and concerted study efforts have been made by huge collaborations, and it's made huge strides in terms of how it's taken care of. However, that also leads to big challenges in trying to change any sort of paradigm in management. So as we all recall, the metanephroblastoma meets the ureteric bud, and when that happens, branching occurs and then kidneys form. If there are any kind of remnants of that metanephric blastema, right, that remaining blastema is what eventually becomes Wilms tumor. And the common presentation for Wilms is either belly pain or, frankly, belly distension, often asymmetric. A parent looks and says something's wrong, right? And they can feel there's a big hard mass in the belly. Sometimes it's incidental. You get imaging because of something bad that happened. You're like, oh, geez, there's something worse happening on the inside. It can be associated with high blood pressure, gross hematuria. But you can imagine that if you're palpating a mass in a kid, this tumor is already really, really big, right? When you see a kid with potential Wilms, you obviously have to look for associated syndromic features like anuridia, hemihypertrophy, pedal abnormalities. If you see a varicocele or hepatomegaly, that implies that the Wilms has climbed into the vena cava and is causing poor return of blood flow. It's jamming things up, similar to what you might see for a renal cell. So we said it's common. It's 95% of pediatric renal cancers and 6 to 7% of all pediatric cancers. And in general, pediatric cancers aren't that common. So an incidence of like 8 in a million, or around 1 per 100,000, is really darn high. The classic age is 3.5. Toddler age, 80% present before age 5. But interestingly, as the Northwestern residents well know, Wilms can definitely present later in life, but I think they had an adult presentation of Wilms just this past year, which can also happen. Now, this next part is important, especially for nephron-sparing surgery, but 4 to 13% bilateral tumors. Most Wilms greater than like 85% of Wilms is sporadic, meaning that there is a genetic mutation, right? However, there wasn't a genetic predisposition. 1 to 2% is familial, which means that potentially a gene is getting passed on through the family. But really, the heart of where all of this management for partial nephrectomy or nephron-sparing surgery for Wilms is really with those with associated genetic syndromes. That accounts for a decent amount of them, 10 to 15%. You recall that 4 to 13% bilateral, a lot of them are in this group, right? The ones that the residents should all know about is WAGR, which literally 4 letters: Wilms, aniridia, GU abnormalities, and developmental delay. It's an R because it used to be retardation, which is obviously is a term that we do not typically use anymore. If you're going to remember one gene for Wilms, this is it, WT1 on 11p13. Dennis-Drash syndrome is another one. That one is Wilms tumor with usually ambiguous genitalia or some pretty significant DSD. And these kids get renal failure from mesangial sclerosis. So they often have poor kidney function to begin with and often end up on dialysis, even if they don't get Wilms. This is also a WT1 gene problem. And then lastly, Beckwith-Wiedemann syndrome, which is macroglossia, microsomia. Like, things are big when they are asymmetrically big. And the tumors associated with this would be Wilms, rhabdomyosarcoma, and hepatoblastoma. This one is WT2. So these are the 3 that you should know for your boards. Now, when you look at these different syndromes, there is a different degree of risk for Wilms. For WAGR and Dennis-Drash, you're looking at a 50% likelihood of Wilms. For Beckwith-Wiedemann, hemihypertrophy, familial Wilms even, right, you're significantly lower, 5 to 10%, 30. And then these other syndromes might be higher risk, but they're much less common, right? But there is a decent list of things that are associated with Wilms tumor. And for these kids who are at risk for Wilms, we recommend screening. The standard interval is an ultrasound every 3 to 4 months. This goes through age 7, which puts you well past the peak age of presentation for Wilms. Now, screening does provide a survival advantage. I don't know if it's necessarily a cost advantage, but it's definitely a survival advantage or a diagnosis advantage. Tumors are lower stage of diagnosis. Now, because we've done such a good job over the years treating Wilms, the survival might not necessarily be better, but it gives you better treatment options because you might not need radiation. You might not need as much chemotherapy. You might be able to do nephron-sparing surgery. You can imagine if these are predisposed to bilateral Wilms and they're to the point where you have to remove both kidneys, well, you might have saved them, but you create a lot more problems. Now, there's a little bit of a controversy for when to screen. Clearly, if greater than 5% risk, you should screen. But many people think greater than 1% risk. I will say it's probably not cost effective at greater than 1%, but there aren't a lot of parents who would necessarily be arguing that if they're diagnosed. Standard imaging is ultrasound, abdominal mass, skin ultrasound. A lot of times it's not Wilms, it's actually a big hydronephrotic kidney. That's much less frequent now than in the past with prenatal screening. Kids should either get a contrast CT or an MRI after the potential Wilms diagnosis on ultrasound. 3-dimensional imaging will give you a much better sense of what's around it, what kind of potential local invasion you see, and then frankly, what the blood vessels look like. Wilms can have all sorts of funny things associated with it, calcifications, changes in fat density. You can see it invading into the drain, into the collecting system. They can have vascular thrombi. They can be cystic, they can be solid. It's a pretty heterogeneous kind of picture. Often we pair this with the CT of the chest because the lungs are the most common metastatic site. Staging is important. Stage 1 and 2 are low risk, typically completely limited to the kidney and no more residual tumor after excision. The difference between 1 and 2 is with 2 it goes through the renal capsule, but it's completely excised. Stage 3 is when you start worrying about increased need of radiation for local control. And obviously, if there's any residual tumor because of incomplete excision, peritoneal spillage from even before operating, as the tumor potentially can rupture, or tumor rupture during surgery, you're going to have worse prognosis, and you're going to need higher levels of treatment to cure. Stage 4 is metastasis, and stage 5 is bilateral involvement, because bilateral involvement is going to change how you manage things. Histology can be triphasic, blastemal, stromal, epithelial, kind of implies which part of that premature tissue developed the tumor. 90% will have favorable histology. And, sorry, is there a question? So 90% will have favorable histology, but there are kids who have anaplastic changes, which typically lends to poor outcomes. The two most important prognostic factors for survival or treatment are tumor histology and stage. And this becomes important when we start looking at some of the data for partial nephrectomy. Oh. Yeah. So treatment could involve surgery. So treatment pretty much always involves surgery if you can. Chemotherapy, and then radiation therapy for those who are grade stage 3 or 4. The overall survival for Wilms, it probably is actually greater than 90% with multimodal therapy. And obviously this does kind of depend on stage of diagnosis. In the United States, it's relatively high. In sub-Saharan Africa, it's actually lower than this, and a large part of it comes down to availability of healthcare. From a renal treatment risk standpoint, you can imagine if you're doing a radical nephrectomy, well, you've removed half the nephrons at the beginning. Now, those kidneys are often replaced with tumors, so a lot of those nephrons have already been lost. Chemotherapy obviously can have nephrotoxic effects, and radiation therapy can lead to radiation nephropathy. So all of these treatments we have for Wilms potentially can affect kidney function. And then again, this becomes important with the discussion for whether or not nephron-sparing surgery has a role. Now, the thing I find fascinating about Wilms is just how well coordinated its management has been over the years. And the fact that surgeons and oncologists can get together and come up with these big treatment plans that get followed across countries is pretty impressive. The three big groups are the National Wilms Tumor Study Group, which is kind of folded into the Children's Oncology Group, which is last on this list. I'm not going to butcher this in French, and I'm purely going to call it SIOP, which is the European branch. In the United Kingdom, similarly with Brexit, separates from all of Europe, and they have their own UK Children's Cancer Study Group for Wilms. There's a major difference in how Wilms is managed between the groups. NITWITS and COG typically recommend surgery as the first line therapy, right? They want the histology, they want the staging before any sort of chemotherapy. And there's advantage to this because if it's anaplastic, for example, it's going to grow with chemotherapy. At least you got more of the tumor out up front, right? You have a better understanding of what's happening with the tumor. Now, the European at SIOP does chemotherapy first. The advantage to this is that when you give the chemo, and they do not do any biopsy, no guarantee that it's Wilms. The advantage to this is you can shrink tumors. That decreases the risk of spillage during surgery, and spillage, right, bumps you from stage 2 to stage 3, right? And because the tumors are smaller, surgery potentially is easier, right? The downside, though, is they treat up to 5% of kids who don't have Wilms. They have some other sort of pediatric tumor, right? Pediatric renal tumor. In the UK, well, they kind of hedge their bets. They don't resect, but they do an upfront biopsy unless it's small and easy to resect. And then they're able to avoid chemotherapy for the tumors that are not Wilms, right? And potentially give more accurate chemotherapy for those cancers that are non-Wilms. But the problem is you upstage them because you did an open biopsy, right? So from a surgical standpoint, pretty similar cancer. Pretty similar cancer goals as with any sort of radical nephrectomy. However, a couple differences. It's typically a transperitoneal approach. You have to explore the entire abdominal cavity for local extension and peritoneal seeding. And obviously, with any cancer, you want to avoid tumor spillage and rupture. However, Wilms is a very friable tumor. It is easy to rupture a Wilms. It's certainly easier than rupturing most renal cell carcinoma. The IVC and the renal vein should be palpated to make sure that nothing's extending into there. And there's a decent percentage with extension into the IVC. And then you should always do a lymph node sampling. You do not have to do a full template, RPLND, but you need at least 7 lymph nodes, right? Standard recommendation. And these are the ones that are around the renal hilum. And then you march up and down the cava or the aorta, depending on the side. Now, neoadjuvant therapy given everywhere, given to everyone in the SIOP or European treatment, but in the United States, we do neoadjuvant therapy if the tumor is thought to be inoperable, and often inoperable tumors are determined at the time of surgical exploration, or if the tumor thrombus is above the level of the hepatic veins, you know you're not going to be able to get it all. And ideally, you can shrink it then. Or if it's just a really big tumor invading surrounding organs, you can decrease the amount of overall damage that you do with your surgery. If there's disseminated disease, you already have Mets, you're going to use neoadjuvant chemotherapy, and then bilateral Wilms tumor. Or Wilms in a solitary kidney that you're trying to save as many nephrons as possible. Standard chemotherapy has been Christine, dactinomycin, and doxorubicin. And then for stage 3, you add radiation therapy. If there's diffuse spillage, you radiate the whole belly instead of just the flank. And you can radiate the lung if there are pulmonary mets. All right. So this is a case of a kid we operated on, 4-year-old boy, hereditary spherocytosis. So these kids can get splenomegaly, and mom noticed that there was abdominal asymmetry, brought him to the ER, and because she felt this big mass in his belly, CT scan was done. And you can see there is a very, can you guys see this pointer or no? Can you see this?
Yes.
Okay, so you can see there is a very large left-sided abdominal mass. It is not associated with the spleen. You can see here's the remnant of kidney here, gigantic tumor. But wait, there's actually 3 little lesions on the 3 lesions on the other side as well. So this kid has bilateral Wilms. Recommendation is chemotherapy. They got 6 weeks of chemo, repeated the CT scan, and this is what we see here. Good response. These tumors on the right side have shrunk nicely. The left-sided tumor has actually shrunk pretty nicely. You can see, though, it comes right up to the hilum, right up to the collecting system. Right, so the right side's obvious. 3 wedge resections to get rid of these 3 little lesions. The left side, we ended up doing a heminephrectomy, cut through the entire lower pole infundibulum, stented the kid through the infundibulum down to the bladder, and basically had nothing to close, so we left a raw surface and put like Surgiseal and all sorts of stuff on it. This is his post-surgical imaging. He is still, he's like 2 years out now, still in remission. So bilateral Wilms, when you see it chemo, like with this kid, you evaluate for the response to chemo. If it's a good response, then you go in there and operate. If it's a poor response to chemo, you biopsy the tumor because you're expecting anaplastic elements. And with those anaplastic elements, there's a different chemotherapy course that you would go through. If it feels like it's amenable to partial nephrectomy, then you move forward with chemo. Then you move forward with partial. If not, it's 12 more weeks of chemo to see if you can get it even smaller. Standard approaches would be through a chevron, transverse, or midline incisions. Honestly, I've only done it through a big midline incision. And ideally, you do bilateral partial nephrectomy, but depending on what's residual, you might do a unilateral radical and a contralateral partial, or sometimes bilateral radical, because at the end of the day, cancer control is number one for what we're doing here. Other indications for nephron-sparing surgery besides bilateral tumors are tumors in a solitary kidney, or kids who have a predisposition to tumor, like the Beckwith-Wiedemann, Wagger. Now, Dennis Drash is not here for a very specific reason. Those kids often end up in renal failure. It's like an 80+% likelihood of renal failure. If they have mesangial sclerosis, if they're already demonstrating evidence of renal failure, you're not going to save the contralateral kidney. So they often end up getting bilateral nephrectomies at the time of Wilms diagnosis, right? If patients already have pre-existing renal insufficiency, you try to spare as many nephrons as you can. And those patients then would be potential candidates for nephron-sparing surgery. If you have multifocal unilateral disease, implying that you're more likely to get more tumors in the future, and removing a whole kidney for 3 small lesions like that one we saw isn't the best choice. And then in general, if the tumor's in a really good anatomic location, well, maybe it'd be worthwhile doing, like a lower pole hemi might take care of this, even though it's a big tumor. And then you don't want any blastemal elements in that kidney, because those blastemal elements, which we really didn't talk about, have the predisposition, have the propensity to turn into Wilms. So if we're going to do nephron-sparing surgery, we have to prove a couple things, right? It has to be feasible, it has to be safe, right? We have to be able to achieve good cancer control. But at the end of the day, we also want to know that it's going to help preserve renal function, because if it doesn't make a difference, then what's the point of going through something that potentially is higher risk? So when we look at safety or feasibility, one of the more recent studies to look at this, to look at this, single center, 99 patients, they matched 55 with nephron-sparing surgery with 55 who had radical nephrectomies. For the nephron-sparing surgeries, the large majority of them, 46, had bilateral disease, right? 9 had a solitary kidney. So you're looking at over 100, you're looking at close to 100 renal units that were ultimately operated on. Actually over 100 renal units, 101 renal units that are operated on. Stage is greater for the kids with a radical nephrectomy. So despite trying to match them, the majority of them were higher stage. EBL was greater for nephron-sparing surgery than for radical nephrectomy. Positive margins were greater for the nephron-sparing surgery than radical nephrectomy. And when you look at complications within 30 days, there was about 3 times more for the nephron-sparing surgery. Now, a lot of this makes sense. You're not going to get a urine leak with a radical nephrectomy, right? But prolonged urine leaks occurred in 9 kids. Infections, both of the surgical site as well as urinary tract infections in 8, transient renal insufficiency and intussusception in 3, compared to 4 infections, 3 intussusceptions on the radical nephrectomy side. However, all of these complications were successfully managed. And keep in mind, you operate in 1 kidney for the radical nephrectomies. And for the nephron-sparing, it was a total of 101 kidneys. So twice the number of kidneys were being operated on for the nephron-sparing surgery, which potentially can account for some of these complications as well. One of my friends, actually, John Ruth, did a study using the nationwide readmissions database, where they looked at all the radical and all the partial nephrectomies in children, adolescents, and adults, and young adults. These are not all Wilms tumor. That database didn't have the ability to sort out the tumor type. And ultimately, they had a lot of kids in there, 3,000 radical nephrectomies, 1,300 partial nephrectomies. And they looked at complications for this group overall. I'm sorry, this is small, but you can see postoperative complications for the partial nephrectomies was 11% compared to 13% for radical, right? And then if you look at specifically nephrectomy-associated surgical complications, it's actually a little bit lower for the patients with partial nephrectomies versus radical nephrectomies. Now, they looked at length of stay, which was shorter for the partial than the radical, and they looked at cost, which in their estimation was which was a sign of just how complex the post surgical care was, and that was lower for partial nephrectomies, right? Oh, I did have a blow up of this, sorry. So, but one major problem with all of this data is that, you know, they're not matched stage for stage, right? And while we know that the stages were higher for the radical nephrectomy and the partial nephrectomy in these, but there is actually no accounting for histology in any of these studies. That just wasn't, none of these studies were granular enough to look at whether or not histology played a role. And we know that that's one of the biggest issues in regard to tumor prognosis, right? So can similar outcomes be obtained to radical nephrectomy? Maybe. I mean, it's certainly, it's one of the things that we're clearly concerned about, and we'll see what the data shows. But one question for what an oncologic outcome is, well, is negative margins? Is it whether or not you had increased rupture? Is it just tumor-specific survival? And unfortunately, when you look at a lot of these studies, the data is varied. So, same friend, John Ruth, he's a urologist at Duke, or pediatric urologist at Duke, did a qualitative systematic review. So they looked at 694 articles and they drilled it down to 66 articles that they included. And after reviewing these articles, they knew they could not do a meta-analysis because at the end of the day, the data was too heterogeneous. There wasn't a way to pull data from all of the studies, which would allow them to actually make any sort of reasonable statement. So the 91% of the studies were retrospective, 4,000 total patients included, 26% underwent nephron-sparing surgery, so a quarter of the population. The patient populations were very different. Were fairly different. The tumor size and stage were clearly higher for kids undergoing radical nephrectomy. A greater percentage of kids had chemotherapy within the nephron-sparing surgery group, and this actually skews both with the American studies and not just because partial nephrectomy is more common in the European studies. And the overall stage obviously was lower for nephron-sparing surgery. So you're not necessarily comparing apples to apples from a cancer control standpoint. When they looked at the rupture rate, it was lower for nephron-sparing surgery. The tumor recurrence rate was the same, and the overall survival rate was the same. Now, when they stratified these kids over time, the kids who had surgeries in the 80s had a lot lower survival than the kids who had surgery more recently, which really reflects an advance in our treatment of Wilms overall. And I think the shocking thing is that 87% survival in nephron-sparing surgery versus 61% radical nephrectomy in the 80s. Does that really mean that nephron-sparing surgery was better? No, it's just that it was only given to those who had small tumors, right? But these results are encouraging despite the fact that the tumor sizes are different. The Wilms stage was lower for nephron-sparing surgery. They didn't stratify by histology. And more of the kids with nephron-sparing surgery end up with neoadjuvant chemotherapy. The other problem is if you're going to publish on your institution doing nephron-sparing surgery, you're probably pretty happy with your results. There's some degree of reporting bias that goes into all of this, right? And ultimately, from an oncologic outcome standpoint, look, we show that the data shows that in a specific patient population, right, with smaller tumors, you know, you're getting pretty darn good survival for kids with Wilms, right? So there is a future role for nephron-sparing surgery in the management of clearly bilateral Wilms, but is there a role for unilateral non-predisposition Wilms? Well, if it's going to play a role, you have to not just show that it's just as good from a cancer outcome standpoint. You have to prove that you're going to have functional benefits, particularly in regard to renal function and the eventual need for renal replacement therapy. So the risk of renal replacement therapy after unilateral nephrectomy for Wilms, it's 0.7% at 20 years. That sounds ridiculously low, less than 1% after 20 years. Now that risk goes up with bilateral Wilms, so 4%. Metacrous Wilms, it goes up even higher, right? 20%. Now that kind of makes sense because with metacrous Wilms, you probably did a radical nephrectomy at the diagnosis of the first tumor, and then you only had one kidney to work with, where if you were bilateral to begin with, like the kid we showed, you would imagine, well, you're going to try to spare both sides, right? So there's half of a left kidney that if it was a unilateral left tumor, we would have taken the whole thing. Now, here's the thing about kids, though. If your average age of getting Wilms is 3.5, 20 years, you're at 23.5. You're not, it's great that only 1% of them have renal failure, but what about 20 more years after that? Because that kid should have a lot longer to go than 23.5 years. This is a little different than doing a partial nephrectomy in a 70-year-old and saying that they're fine after 20 years, right? And these kids had normal kidney function to begin with, by and large, right? And we know that these kids with Wilms, even though they're 0.7% need for renal replacement therapy, a decent number of them have some degree of chronic kidney disease. A decent number of them have hypertension, proteinuria, some sort of issue with kidney function. Right? If we were to extrapolate some adult data, and you know, for partial nephrectomy on the adult urology side, there's a decent number of studies that demonstrate risk reduction for chronic kidney disease with partial nephrectomy versus radical nephrectomy. And you can imagine that, well, if your GFR is normal, you're over 100, and you do a radical nephrectomy, well, that other kidney is going to compensate, you'll make up for it. But we all know that the majority of our adults are not necessarily at a GFR of 100, certainly not the majority of our 70-year-olds. So it's not unusual to do a nephrectomy and to see some degree of bump in the creatinine or decrease in GFR, because they're not starting with normal kidney function. So for these adults, it's very clear that if you do partial nephrectomy, there's a decreased risk of chronic kidney disease, as this meta-analysis demonstrates. When you look at kids, you see some pretty interesting results, actually. So this is a study out of Denver by Nick Cost. They asked the very specific question: nephron-sparing surgery, radical nephrectomy, non-syndromic unilateral Wilms. They went around the world, multiple institutions, and scoured up 15 total patients. So as we said before, because of how organized Wilms management has been, to do nephron-sparing surgery on unilateral non-syndromic Wilms is incredibly rare. This is kind of a Punnett square of data. So this is the eGFR diagnosis. So actually lower for the kids with nephron-sparing surgery than those with radical nephrectomy. 150 GFR is hugely normal. Their GFR post-op for the radical nephrectomy decreased to 131, but the GFR, which was a significant decrease, the GFR for kids with nephron-sparing surgery increased to 135. I cannot explain that, and I can't really understand it based off of their data. But essentially, if you're doing nephron-sparing surgery, you're certainly not seeing a decrease in GFR. That's very encouraging for long-term renal function. This paper came out in 2020. They did a meta-analysis comparing nephron-sparing surgery and radical nephrectomy. They included 20 studies, including that cost study that we just looked at, and they compared change in GFR. This is a ratio, so the 0 is no change, right? I guess it's not a ratio. It's a ratio, because I think it's 0 is no change, and then like one-fold this is an increase, right? So the same thing, what they found was radical nephrectomy. In general, you're kind of hovering around no change. There are definitely studies that showed significant decrease. There are studies that showed some increase. But this is the 0 line here for partial nephrectomy. The majority of these studies demonstrated that after you did nephron-sparing surgery, you had an increase in the GFR. Again, I don't completely understand this, but it does look like from a functional standpoint that we potentially are preserving long-term kidney function. Now, we haven't done enough partial nephrectomies for enough time to really track these kids who are now 40 years out, because there aren't that many of them in existence, right? So that's data that needs to be generated in the future from an adult institution, because we don't see them anymore on the pediatric side. So when you think about renal outcomes, overall for Wilms, the initial NITWIT SIOP studies were done on, well, how do we increase treatment to improve survival? And they added chemotherapy. They changed how the surgery was done. They added lymph nodes, and they saw an improvement in success. When they reached a certain degree of success improvement, they said, wait, the later NITWIT studies and the COG studies actually looked at, well, how do we reduce chemotherapy? How do we reduce radiation? How do we reduce the morbidity from these treatment goals? Well, obviously, renal failure is one of these risks for Wilms. While it's low overall at 20 years, we know that from all comers, when you study children's cancers, they end up with cardiovascular issues. Those can lead to problems with kidney function. And if you're already behind the 8 ball in regard to nephrons, well, you're probably at greater risk. We know that these chemotherapeutic agents are toxic to the kidneys. 20 years is not long for our pediatric patients, right? The question is, what's the 50-year renal failure rate for these patients? So if in selected cases, nephron-sparing surgery can actually decrease your renal morbidity, well, maybe we can apply this to more patients who only have unilateral disease. This is a little bit of a sad story. This was a kid that I saw about 2 years ago. 2-year-old boy, Wagger, so 50% risk of Wilms. He had this little irregular cyst on a screening ultrasound, right? We got an MRI, right? And you know, it's not super impressive. We waited a month, got another MRI, and you could see that this lesion has grown. We presented this at the tumor board, and what they said was, well, this is probably Wilms, 50% likelihood. It grew rapidly within a month, and they gave him a 6-week course of chemotherapy. This is what the kidney looked like 6 weeks later. So this tumor grew. We went in to do a partial and ended up doing a radical nephrectomy, because by the time we cored this out over here, the hilum was gone, right? Now, sadly, he actually had favorable histology Wilms, which didn't exactly make sense in regard to not shrinking, because that's typically what you'd expect with anaplastic, right? This happened a couple, maybe like a month ago. 3-year-old girl, Beckwith-Wiedemann syndrome, left-sided renal mass on an ultrasound. It had grown from 1 to 1.5 centimeters over 3 months. Got an MRI, it was about 1.7, and we did a partial nephrectomy. Unfortunately, there was tumor spillage on this one, which upgrades her, but the margins were negative. So in terms of answering the question of if there's a role for nephron-sparing surgery for unilateral non-syndromic Wilms tumor, I mean, a little bit of this is a thought process, right? Because if we can achieve survival rates that are similar for kids with predispositions undergoing nephron-sparing surgery, and we can, right? Then, and we're showing that we can potentially preserve renal function, then shouldn't we recommend partial to everyone who's amenable to it? And interestingly, SIOP, under their umbrella protocol, which includes Wilms plus non-Wilms renal tumors, non-Wilms renal cancers, has a protocol now for the role of nephron-sparing surgery in non-syndromic unilateral Wilms. So if there's a small tumor burden, so less than 300 milliliters, there is going to be significant residual normal renal tissue left. Your lymph nodes have to be negative, right? And again, this is SIOP, so all of these are post-chemotherapy. They've seen these shrink. By these criteria, about 3% are potentially amenable to nephron-sparing surgery. But at least that's 3% that they're potentially helping from a long-term standpoint. Where should we go from here? Well, I'm not exactly sure where they came up with the 300 milliliters and these specific criteria. You can imagine a more exophytic tumor, tumors that aren't near the hilum, that are large, potentially can still do well with nephron-sparing surgery, even if they don't meet those particular criteria. We need to overall better define the ideal treatment population for kids who might do well with nephron-sparing surgery. We have to identify tumor characteristics, which are more amenable to surgery. And then frankly, the data out there, you know, it's nephron-sparing surgery. Some people are doing hemis, some people are doing wedge resections. The urologists all kind of have an idea of what a partial nephrectomy is, but a lot of these surgeries are being done by pediatric surgeons. Some of these tumors are being enucleated. It's a mixed bag in terms of technique, and we have to standardize that better. So ultimately, if you're going to do nephron-sparing surgery, number one in your mind should still be cancer control. We have to cure it. We have to give the kid the best chance at fixing the cancer. But in a proper patient, with proper patient selection, partial nephrectomy can provide good cancer control. And there is potential for long-term benefit in renal function that has not been definitively proven, but the early data seems to suggest that, yeah, you've got more nephrons, you're going to do better. But ultimately, if we want to answer this right, we need some randomized controlled trials. And the question is whether or not that'll happen in COG or SIOP. Questions?
So who's your, you kind of mentioned in the talk, but just for the residents again, so who's your index patient for you would definitely do a partial, and who's your index patient for who you would definitely not do a partial?
You know, we are not necessarily pushing for partials in unilateral non-syndromic Wilms. Patients who come in with a bilateral will get chemo and we will attempt partial. Any syndromic patient, we will do partial, even if it's a unilateral. We'll try a partial, even if it's a unilateral tumor, because the risk of recurrence on the other side is that much greater, right? The solitary kidney is actually fairly rare, and my understanding is the majority of the solitary kidneys are the ones that have the contralateral taken, right? It's not that you were born with a solitary kidney and you got Wilms.
Yeah, perfect. Any other questions from the residents or other faculty?
Ed, this is Bill Catalona. Great talk. Great talk. I remember when the Wilms tumor studies didn't recommend lymph node sampling. That was thought to be sort of an overly radical thing to do, but I guess it's now become incorporated into standard treatment. My question is, what chemo, I mean, vincristine, actinomycin D, and doxorubicin are sort of old chemotherapy agents, and we've had a lot of new drugs come along that have, like never been incorporated into pediatric or at least into Wilms tumor treatment. What chemo do they use in the patients who have the anaplastic histology?
Honestly, I do not know that off the top of my head. All right, I could definitely find out for you and get you that information soon.
I'm just wondering whether they use, any drugs like platinum or, some of the newer drugs that have come along. I think vincristine, actinomycin D are so well tolerated that by children, and there's such a long history, and they're so effective that maybe that's why, it's hard to improve on that with 90% oral cure rate.
No, you hit the nail on the head. I mean, that's the thing with, it's great to have these big organizations because it's a fairly rare disease, right? Pooling all these patients so that you can get real data. But the downside is obviously it's not fast. Like change is hard. And frankly, if there's a patient that it's questionable in terms of management, we just contact the Renal Tumor Committee at COG and we say, hey, what do you guys think of this? Can you give us a recommendation? Right? Because so if we're going to do something which is relatively cutting edge or slightly deviates, we want to run it by them to make sure they're comfortable with that. But that also slows down change, right? Because change happens because someone says, well, I'm going to go on my own, I'm going to do this. And other people say, wow, that actually worked. The downside is, man, what we do works. So it's really hard to change, right?
Yeah.
So.
Hey, Dr. Gong, it's Tarek here from the Endo Fellow. Just a quick question here. It seems like all the patients undergoing partials for Wilms are the ones that have the bilateral tumors, which is kind of their only option. So these are already upstaged because they're bilateral. So how do we know that they have worse outcomes because they had partials or because they were bilateral to begin with?
No, you're right. We don't. That's the whole thing. That's the whole thing with this data, right? Because you're not truly comparing, apples to apples, right? Now, it's true that they're bilateral, so they're stage 5, right? But it's not necessarily true that they're stage 5, so they're higher cancer risk, right? Because it's still like if you were to isolate it to one kidney, right? That kidney is actually potentially, that kidney, those two kidneys might have different cancer risks, right?
Thanks.
So when you look at all of this data, you're right. It's hard to say that it's hard to say that any sort of absolutes because that it's just not coordinated, right? But it's not coordinated because there's not a huge role for, no one's studying this specifically for COG, right? Why are we doing them on bilaterals? Because it doesn't take too much thought to realize that having part of one kidney is better than having no kidneys, right? So that's why we're willing to do that for bilaterals, right?
Thanks.
Thanks again, Dr. Gong. That was an excellent talk. Thank you, everybody, for your attention. If there's any other questions, please ask them. But otherwise, everyone have a good weekend, and thanks again for this presentation.
Great. Thank you, everyone.